discuss a new topic, appendicitis. Okay. So, as you know, appendix, where is appendix? It's located near cecum. It develops as a sort of a diverticulum from the cecum, isn't it? And it's about 7 to 10 centimeter long structure having all mucosa, submucosa, and muscular layer, isn't it? All three tinea coli, they converge together to form the muscle of the appendix, and then has serosa lined by columnar epithelium, which has got a lumen. Okay. Position of the appendix, mostly commonest position is retrocecal, about 70%. Can you focus here? It's a retrocecal, isn't it? Retrocecal, behind the cecum. Then another common position, about 20-21% is, okay, is retrocecal, then pelvic, 21%, then you have pre-ileal, post-ileal positions are there. These are the common positions. Okay, so the commonest is retrocecal, then you have a pelvic, pre-ileal, post-ileal. Okay, these are the position of the appendix. So, why does somebody develop appendicitis? What happens? What leads to appendicitis? Basically, the appendicular lumen is obstructed. Okay, appendicular lumen is mostly obstructed by fecolic. Feces and calcium salts form sort of a stone-like structure called fecolic. They block the lumen, and this is the commonest cause of blockage of the lumen. Other causes can be lymphoid hyperplasia. You know, the appendix has got a lot of lymphoid follicles, so lymphoid hyperplasia can lead, and rarely sometimes carcinoid can lead to appendicular appendicitis, obstruction of the lumen. Also sometimes foreign body like nuts and peas and some substances like that can get lodged in appendicular lumen. But by far the commonest cause is fecal. That causes the obstruction of the lumen. Then fluid accumulates there, secretion, mucus and fluid accumulate there, that can become infected, and that leads to swelling of appendix and inflammation of the appendix. This swelling, this obstruction and accumulation of infected fluid can further aggravate the condition and can lead to impairment of venous return and ultimately arterial supply, and lead to gangrene of the appendix. Okay, so fecolith leads to obstruction, distension, luminal distension leading to venous and arterial occlusion and gangrene, which can lead to perforation of the appendix. So this is the pathology what happens to the in appendicitis. Sometimes only the luminal obstruction occurs, catarrhal inflammation occurs, and if the obstruction is relieved and patient is put on antibiotic and all, that can relieve by itself. So all appendicitis doesn't progress to gangrene and perforation. Okay. So this is the pathology. Now, how does a patient present to you? Usually, what they will complain. Patient usually come, which age group? Usually it occurs in any age group, but the commonest is about 20, 30 teenagers. They usually get the appendicitis very commonly, but it can occur in infancy also, it can occur in elderly also, it can occur during pregnancy also. Okay, the commonest is about 20s, highest incidence is there. Now what happens in appendicitis patient, what complains of first is periumbilical pain. Periumbilical pain. Okay, why periumbilical pain? Because the lumen gets obstructed, then there is distension of the appendicular lumen, and that is a visceral pain. Okay, a visceral sensation occurs around T10 area, periumbilical area. Later on, this inflammation in the appendix passes from mucosa, submucosa to serosa, and that serosa comes in contact with the parietal peritoneum and irritates the overlying parietal peritoneum, so the patient gets pain in the right iliac fossa. right iliac fossa, isn't it? Mostly if it is in the if appendix is lying in that region. So pain first in the periumbilical region, then shifting to the right iliac fossa is characteristic. Then your patient will complain of nauseatic feeling, nausea and vomiting. Here the vomiting occurs after pain. Okay, first pain occurs, then vomiting occurs. Whereas in intestinal obstruction, it's the vomiting which occurs first and followed by pain. Okay, so here in appendicitis, you get pain first, then you get nausea and vomiting. Mild fever might be there. Anorexia is there, very characteristic. Patient doesn't feel like eating. Okay, so these things occur in patient. What are the signs which occur when you examine these patients? You will usually find tenderness in the right iliac fossa. That is very important sign. We'll have tenderness in right iliac fossa. When we press on the left side, because of the migration of the intestine and hitting here, patient can have pain. This is sort of a pain because of the pressing here. That is called Rossing sign. When you press the opposite iliac fossa, patient can have pain here in the right iliac fossa. This is Rossing sign. See, if the appendix lies behind the cecum, as it is mostly on the psoas major muscle, then patient usually flexes the hip. Patient, that relieves the pain. So when you extend the hip, that is called Cope's test. When you extend, that is called psoas test. When you extend the hip, the patient will have pain. That suggests that is retrocecal appendix lying on the psoas major. If an appendix is lying in the pelvis, pelvic appendix on the obturator internus muscle, then when you flex the hip and internally rotate, patient will have pain. Okay, so appendix lying in the pelvis in contact with obturator muscle, if you flex the hip and internally rotate, they will have pain. This is called obturator test. So you had psoas test, obturator test. Psoas will tell you that appendix is lying on the psoas major. Obturator test will tell you that appendix is lying irritated in the pelvis on the obturator internus muscle. See, if patient coughs, the intra-abdominal pressure rises, patient can get pain. That is called Dunphy's sign, D-U-N-P-H-Y, Dunphy's sign. Okay, so any intra-abdominal movement and will hit the appendix and cause patient to have pain. Here the pain is because the serosine, framed serosine lying in contact with the parietal peritoneum. Okay, you might later on you might feel an appendicular lump here. If perforation occurs, if appendicular, there might be a localized collection, localized abscess, or there might be a generalized collection. Generalized peritonitis can occur because of the perforation and all. So appendix can even lead to, sometimes if not diagnosed and not treated properly, can lead to even death. So appendix, these are the signs of appendicitis. Tenderness in the right iliac fossa, Rossing sign, that is pain on pressure in the left iliac fossa. Then you have pain on extension of the hip, that is called that is a psoas test. Then you have pain on flexion of the hip and internal rotation because of the obturator, that is called obturator test. Okay, so when you do investigation on these patients, you will find that total WBC count is raised, usually above 10,000. Neutrophil is above 70%. Okay, CT scan can tell you, can show you the appendix where the lumen is widened, the wall is thick, there might be collection there. Okay, ultrasound is a bit less sensitive, but it can be used also. But mostly the diagnosis of appendicitis is clinical diagnosis based on these things. If you have any problem, you can go for CT scan and also, and if needed, if not available, for ultrasound. Okay, so how